Hello and welcome to episode 119 of Chairside Live. We've got a good episode for you today. We've got part two of my interview with Dr. Paul Homoly, and he goes through what he likes to call the discovery guide. And this is where you go in and you diagnose what's in the patient's mouth, and then you communicate it to them based on needs that they're aware that they have and needs that they're not yet aware that they have. So it's an interesting way to present treatment and hopefully ultimately get the patient to say yes to those treatment recommendations. In our case of the week, we're going to take a look at a couple different occlusal splints after a doctor sends one in to have it fabricated. And it's pretty much everything you ever wanted to know about occlusal splints, but were afraid to ask or too bored to ask. But now you're going to learn today whether you want to learn about it or not. But before we get to that, two quick points of business. The first one is we had been struggling with one of our dentists here who was having problems with the set of his impression material. It would come in looking kind of slimy sometimes, and we'd been through all the typical things, gloves, powder from the gloves, things like that, things that really haven't seemed to make a difference, to be honest, in the last, say, 10 years. And it always seems like it's probably something related to an astringent. So he went on a certain cases and he wouldn't use anything. He picked cases where there wasn't a lot of bleeding and he didn't have to use something like viscostat. So we eliminated those as well, and we eliminated what we thought was just about everything. And he was still getting some slimy impressions. And what it finally turned out is this is the doctor who likes to prepare the teeth, and then before he actually makes the final impression, he does the temporaries. And so he or his assistant is able to trim the temporaries, work on the embrasures, and do all that stuff for the 4 minutes while the impression is in the patient's mouth. And we realized, as I thought I just tried it here once in the operatory. I've never really done it that way. And when I tried it, I could see instantly what it was, that kind of gooey, slimy, air-inhibited layer that a bisacryl material leaves on the prep. And that will absolutely inhibit the set, at least of that surface layer of polyvinyl siloxane material. And so if you are somebody who likes to, before you actually take the impression, go back in with your original pre-op impression and make your bisacryl temporaries and then trim them or have your assistant trim them while the final impression is in the patient's mouth, just be very careful and go in with a hygiene cup and some pumice and clean off all the preparations. And anywhere where you're not doing that with the pumice, maybe on the soft tissue, go in there with some alcohol-soaked 2x2s or some cotton pellets, and make sure you get rid of all of that air-inhibited layer, any of that slimy, kind of shiny stuff that you can see, the kind of stuff that you'd see on the top of a composite just after you cured it. And that type of material, that air-inhibited layer, will in fact affect the set of your polyvinyl siloxane or your polyether impression material. So it was nice to finally get some clarity on what was going on there. And now, since the dentist has started cleaning it up, or in certain cases not doing the temporary right away, like on most of his single unit cases, we've seen that the impression material now in fact is setting completely. So it's not a problem with a bad batch of material or any of the stringents that the dentist was using. So nice to be able to wrap that up, and something to think about if you like making the temporary first. Also, one of our faithful viewers, Dr. Marshall Horowitz, somebody who has written in, had questions read before, has won prizes, the Chairside Live coffee mug and some other ones, actually took it upon himself to make a Chairside Live t-shirt for himself, something that I don't even own. And it got interesting when, as part of his philanthropic efforts, he actually goes over to China or Mongolia, and has for many years in a row, and donates dental services over there. And this year we were able to help him out by donating some materials to help make his job a little easier when he goes over there. And it was funny to see some of the pictures that he sent back to us. This is probably the first time we've ever had a Chairside Live t-shirt and an actual edition, a paper edition of Chairside magazine in Mongolia, as Marshall poses with some of the patients that he saw. They're all looking pretty happy. And then he sent an actual picture of himself working on a patient while wearing the Chairside Live t-shirt. And it's, yes, one more satisfied customer. So I don't know if he told her to smile. He's smiling. I don't know if it's, I don't, does she appear to be in pain? I can't really tell if she's in pain or not, but when you see a lot of the other pictures that Marshall sent me, if you've done trips like this, like the ones we've done to Mexico, people are very, very happy to welcome you into their village and have you treat them, because on the few occasions where they've been treated by a local or maybe try to do it themselves, they did not have any local anesthetic. And so it's almost a dream come true for them to be able to be treated by somebody who has some of these modern materials. And Marshall was nice enough to take these pictures for us and send them back, because we donated some anesthetic and some other supplies to them to be able to use when they got down there. So Marshall, thank you very much for those pictures. Those are going to go up on the walls here in the studio of Chairside Live, and I like that. I'd like to see if we can't get a picture of a Chairside magazine or a Chairside Live t-shirt on all the continents. I'd like to see one on Antarctica. I'd like to see one almost everywhere, but starting with Mongolia is a good starting point. That's a lot more impressive than, say, Vancouver, Canada. So congrats on that, Marshall, and thank you for all the kind work you do for the people in China and Mongolia. Now let's go ahead and take a look at the case of the week. Most of the dentists who are sending us splints are taking alginate impressions in their office, pouring these up, and then sending the models to us separately. So we end up getting models in the mail like this, and they're taken from alginate. And if they're taken properly, where you smear alginate on the occlusal surface with your fingers in the patient's mouth before you take it, you can definitely get a pretty good result with alginate. Pour it up, obviously, as quickly as possible, and then leave the model actually in the alginate impression and send that to us. You'd be surprised how many thin models we get, and as a result, we receive more broken models than we care to get, and then you care to get, because you have to have the patient back and take another impression. So when you pour your alginates, leave them in the impression tray and actually send it out to us like that. It acts as a protector for the model, and we'll separate the model when it gets to us here in the laboratory. That's probably accounts for, probably 60 or 70% of the cases we get. And then the rest are impressions that are sent in from the dentist. If you're going to send it to us, please take it in polyvinyl or an alginate substitute material. To wrap it in a wet paper towel and send it in a baggie is just not going to get it done. And there are a lot of fit-related issues that we see related to distorted impressions. It really is the best way. If you want to take polyvinyl, and no need to pour it in your office, just send it to us. If you're going to take alginate to save money, take it, pour it immediately, and then just leave it in the model and send it out to us. Most of the dentists that we get send us a bite, where what they'll actually do is take bite registration material and they'll squirt it along the patient's lower arch, and then they just have the patient close completely together in maximum intercuspation. And so we end up with a really thin strip of bite registration because the patient's biting all the way together. This really doesn't do anything for us, and we really don't need it. In fact, if you just want us to determine the thickness of the occlusal splint for you, just take a very nice upper and lower alginate impression and pour it yourself, or take polyvinyls and send it, and we will hand articulate the models. You don't even need to take that bite registration. But if in fact you want to determine the position the patient's going to be in, the thickness of the occlusal splint itself, you can certainly do that. There's a couple ways to do that. We have a video on our website showing how to do it with 2 cotton rolls, where the patient bites down into 2 cotton rolls, and then we do bite registration material here in the anterior, and then one on the posterior and one on the posterior over here. So we have a tripod, 3 little bites while the patient relaxes onto those 2 cotton rolls. I've seen doctors use golf tees. We literally will see golf tees that come in. They're kind of stuck to the bite registration, or even something like the handle of this scalpel could work, where the patient just bites and then something stops them from biting all the way together, so that you have a couple millimeters of space in between their posterior teeth. So there's different gauges and things that you can use to stop them when they bite together. And when we make a splint like that, we use these articulators. This is a Galletti articulator. I don't know if you're familiar. You probably haven't seen one of these. It looks like something from maybe the turn of the century, and actually is designed a long time ago. But one of the nice things about it is it's a stone-free mounting, so the models just screw right into that articulator. That's one thing we like about it. Not only does it end up being cleaner, but you don't have the distortion from the mounting stone that typically holds these casts to the articulator itself, which can throw the bite off. So we feel it's very accurate. And then we can open, with this screw right here, we can actually open these two models apart from each other in a straight vertical direction to create thickness for a splint. So if you have a splint that you send to us and you want it at a certain diameter and you used a couple cotton rolls to take the bite like this doctor did, we can make a splint for you to that exact dimension and replicate that on the Galletti articulator. And so that's another reason that we like to use these articulators if you have something of a known thickness that you want. Now, most of the splints that we make are in fact this hard soft material, our comfort splint, as I wiggle this off, and you can always tell it's one of those by when you take your fingernail on the inside and you squeeze it into it, you can feel that soft layer. And one of the nice things about these hard soft splints is that if the patient doesn't wear it because they're not grinding their teeth for say 4 to 6 weeks or maybe even 2 or 3 months, when they go to put this back in again, a lot of times if the teeth have shifted around, which teeth have a tendency to do, it can be very tight in certain areas, and with this soft layer on the inside, now all of a sudden it'll accommodate a little bit of that tooth movement as long as it hasn't been more than a couple tenths of a millimeter. Beyond that, it's a little more difficult to do. So this is our most popular splint. It's a very easy one to work with. It's comfortable because it's hard on the outside with the soft layer on the inside, but there's times where we don't quite have enough retention on the teeth. There's not enough undercut, and so we'll often call you and tell you that we want to switch you to something called an Astron splint, as you see here. And one of the differences with the Astron splint is you can see the little ball clasps that we have. So this material allows us to use some ball clasps to get some additional retention in addition to what we already have. And there's some other neat things. This is a thermoactive appliance as well, and in just a minute I'll show you how we can use this. So the Astron is also very good. It's hard, it's fully hard, there's no soft layer on the inside, but it's thermally active, so when we heat this up, we can actually, as you'll see, there's a lot of movement to it, and we can pop it into the patient's mouth while it's soft, and it'll reconform itself to the patient's teeth, and they can bite back into it, and as it cools in their mouth, it readapts itself to the teeth. So that's one of the neat things about this. One of the newer things we have, this is like the hard soft splint that you saw before, except this one's blue. This obviously isn't for daytime wear. This is for patients who are wearing it at night, but clear splints sometimes are a little difficult to find, and so this blue material is not an obnoxious blue, but it makes it easy to be able to find it when it's sitting on your bedside table, or see it if it happens to be in a glass of water, wherever the patient might put it, and it doesn't see the same kind of discoloration issues or the yellowing the way that the clear splints do. So this blue one's been one that's become more popular. This is a regular hard soft splint, and really the only difference is the color of the material itself. So let's go ahead and take a look at what happens if we heat some water up to 150 degrees, and then we're going to place this Astron splint in there for about 2 minutes. So I've heated this up to, in the microwave, to about 150 degrees. So I'll drop the Astron splint in there, and we're just going to leave it there for about 2 minutes. So we can just pretend that we've got a patient who is in for the initial delivery of this splint, and maybe it seems like it's rocking just a little bit or not kind of snapping in like it should. Or this could also be a patient who, as I mentioned before, hasn't worn it for 6 to 8 weeks, and it doesn't seem like it wants to go down all the way. In fact, if you trust the patient enough, they could probably do this themselves at home. If you trusted them to heat the water up to 150 degrees without burning themselves, it's about 2.5 minutes in an average microwave. Or if you trusted them not to put something that was too hot in their mouth. Probably better done by your dental assistant in the office, though, where the temperature of the water can be controlled, and then someone else can be there to put the splint in the mouth, make sure it seats, and then have them close into it. And once they've closed into it and you've let it cool in their mouth for a minute or two, I'll oftentimes take an air water syringe and use air and water to actually cool the splint while it sits on their teeth. So it's been 2 minutes, so let me go ahead and fish the Astron splint out of the water, and you'll notice what I can do with this now. You'll see, you can twist it like a pretzel basically, and it goes back and forth and back and forth. And so we seat this now on our mythical patient on their upper teeth, and then we have them bite together, and they can hold it together tightly for about 2 minutes here. And when it's in the patient's mouth, any little distortions or tooth movement will now be accommodated by the Astron splint. It's not like they can take their wife's splint and you can heat it up and put it in the husband's mouth. But if it's the person's splint and there's been a little physiological tooth movement, you can have them bite together, and again, once it's been in for a minute or two, then you would have the patient open and then hit it with an air water syringe with some cool water to finish the cooling procedure on the splint itself, and then be able to take it out and then re-verify that it fits the patient. So again, that's the Astron splint. It's the one that we use when we don't have enough undercut on the teeth, and so we can put some ball clasps in there that'll help with it. And also one of the neat things about it is that it's thermally active.
Sort of the second step in the Yes Online process is understanding where is the patient aware of their conditions, and as importantly, what are they concerned about and what they're not concerned about. And I provide a tool called a discovery guide. And the discovery guide, let me show you a little bit of it right here. The discovery guide here is sort of a map. And what this map does, it documents what conditions the patient is aware of and what conditions the patients are concerned about. For example, this patient, Michelle, right here, she comes into your dental office and she's very upset about the conditions of her front teeth. 6 to 11, large discolored composite. She's embarrassed by it. She tells you she's aware of it and concerned. So she's aware of it. Yes, she's aware. And she's concerned. Next, you ask her, what else is going on in your mouth? She says, well, I've got this pain on I think it's my right side, but sometimes it's the left side. Sometimes it hurts, sometimes it doesn't. She has what we call disability. That is, there's something that's bothering her, Mike, but she's not sure what it is. She's not aware of the condition, but it bothers her. So it goes into this quadrant here. Next, you ask her, anything else going? Well, I'm missing a couple of her back teeth, but they don't show when I smile. She knows about the condition, but the condition doesn't bother her. So she's aware of it, but no disability. Finally, you say, Michelle, anything else bothering you? She, other than that, I'm fine. You look in her mouth, and she's got gum disease. She's got 4, 5, 6 millimeter pockets, and she has
not aware.
She's not aware, and it doesn't give her a problem.
There's no disability.
Now, during the exam, you'll chart the mouth, right? You draw in the teeth and do all that. But also during the exam, I would call out this documentation to the assistant. It's called a mapping. And the assistant has this form. So I would say, okay, mesial distal discolored composite 6 to 11. Suzette, go ahead and map 6 to 11 quadrant number 4. So I would call out the quadrant. And I would do that during the whole exam. Now, the power behind this, when you look at this, there's a leadership adage that goes like this. To influence someone, discuss what's important to them first, important to you second.
Right.
You know,
just like on a date, right?
Exactly.
Tell me more about your mother.
Tell me more.
I just want to hear about your mom and your family.
Yeah, tell me more about your mom. You know, and I learned.
I'm loving this.
I learned this lesson the hard way when I was just coming out of the Pankey Institute in Dawson. I had a great education there, but I was really full of my knowledge. So I'm taking study models and face moves on everybody, and this old timer comes in with a broken tooth, and I'm telling him about centric relation, and he's pointing at this tooth. Finally, I'm saying, no, we need to get study models. He said, no. He said, here's what's wrong with you. He says to me, you need to learn to ride the horse in the direction that it's running. And I thought, what the hell does that mean? Well, he's right. He's right. You know, get on the horse in the direction that it's running. It is learn to speak first what interests your patient. Well, let's go back to this right here. Now, you've done the exam, you've done the mapping, okay? Now you're going to sit the chair up, Mike, and you're going to do the post-examination discussion. Now, which quadrant would you discuss first? Where is the greatest interest of the patient?
Got to be number 4. We know that's why she's there.
Absolutely. And then what would be second?
We would go down to 28 and 29. She knows she's got pain. She's not sure where it is or what the condition is, but something's going on and her body's telling her something's wrong.
Exactly right. In the presence of disability, there's always presence of interest.
Right.
And we're talking about an influencing conversation. So the sequence of the post-exam discussion then goes 4, 3, 2, 1, right? It's a process, Mike. Now, when I say you would discuss perio last, how do you think 99.9% of the dentists would react to that comment? I'm saying discuss perio last here.
Right.
What do you think most dentists would say to that?
They'd probably follow their hygienist and say that's crazy. We got to get the perio in order before we do anything else. 4-quadrant scaling and root planing, and then we'll take a look at 6 through 11.
Sure, absolutely. Here's Michelle. She comes in. She's 43 years old. She owns her business. She wants to look great. Maybe she came referred from one of her friends. She's got that little voice going in her head. I want pretty teeth. I want pretty teeth. Right? All of that. And then you do your exam and you come up, put the chair up, and you shoot her down by talking about perio.
Right.
Now, did I say that this was the sequence of treatment?
No.
No, I didn't. This is
the post-exam discussion.
Post-exam discussion. And it's so a big part of Yes Online, Mike, is to understand the difference between a consent conversation and an influencing conversation. A consent conversation would be in the sequence of treatment. We do the perio first, we do this second, this third, this fourth. But you see, we're not to that point
Right,
yet.
right.
What
We're nowhere near it.
We're nowhere near that. What we
Right.
want to do is have an influencing conversation with the patient. We want to get on that horse in the direction that it's running.
Right.
So for Michelle, I'm going to talk about her pretty front teeth first,
Right.
28 and 29, missing back teeth, perio last. Does that mean I'm going to treat the perio last? No.
Right.
I'll probably treat the perio first, or at least in combination of doing the front teeth there. And so a big part of Yes Online is understanding what bothers you may not be bothering the patient. And if I front load my treatment plan with a lot of discussion with perio, how will that influence Michelle?
Well, it's going to turn her off. You did not hear what she was saying. My what? What's perio?
What's perio? You're going to do what?
Yeah, and my front teeth are ugly. I've got a huge meeting coming up in 2 months where I'm trying to buy another business or whatever.
In 2 months, I get a big black tie affair.
Right.
And so when we
daughter's
take care
getting
of this?
married. Right.
Well, we can't do that until we see what the healing is like.
Right, and our first opening in hygiene for your root planing is in 2 months.
In 2 months. Good luck. So,
well, this is different than what I was taught when I got out of school, and that is if a patient like Michelle wants 6 through 11 done or just one tooth done, you hold that to the end because you know that they're going to continue coming until they get that at least. And so you can do all the other stuff. And it's not unlike the dental school instructor saying, don't make the temporary look too good or they may not come back, which is just a horrible excuse for doing shoddy temporaries.
That's no way to live.
Right.
That's no way to live. You understand, if you address those front teeth with Michelle first, you have earned the right to hold her attention.
Right.
You've earned the right to influence this woman because you've heard her. And that is so important, especially as those fees get higher and higher and higher.
And that's important to women to be listened to? And they do make up a vast majority of our dental patients,
absolutely,
don't they?
More and more. Most of the rehabs I did were on women. And you know, women have got a lot of things to say. And if you understand the basis of the disability, you understand the motive for treatment.
Right.
And then you begin to shape your language. And so instead of me talking so much about the process of dentistry, we're going to prep your teeth, taking impressions, put in the temporaries, I'll talk about the outcomes of dentistry. That is, when you go to your black tie event, you're going to look great.
Right.
That's the influencing conversation. Let me be quick to add, we are going to have consent conversations, but we're going to have consent conversations, and we're going to wait on those until after the patient is adequately influenced and understands the fee and makes the commitment to the case. Then we're actually going to get into the consent aspects.
Okay. You mentioned, when you were mentioning the 4 chiefs, I think number 3 was fit.
Yes.
And you mentioned things such as taking a vacation with the family or other financial, things that might come up too. That's interesting. I was taught to present treatment in a vacuum. Almost like money didn't exist.
Right.
Tell them about the best care available. And
just fold your arms and expect your quality just to wash them into a euphoric yes.
Or leave it up to them to find a way. Maybe they've got money buried in the backyard or a rich relative. But you're saying that there's a dialogue that takes place that takes into consideration whether or not this type of treatment is a good fit in their life right now.
For them. You have to have that conversation. Kind of consider a continuum of dentistry. This dentistry over here is dentistry that's less than $3,500. This is the tooth kind of dentistry, single crown, 2 crowns, up to $3,500, $5,000. And over here is dentistry that's greater than $5,000, $10,000 up here. Well, when you're in the lower fee range, fit, that is life circumstance, has less of an impact on case acceptance.
Right.
insurance is going to pick up half of that case. Care Credit could get involved.
Sure.
Patients can put it on a credit card. So fit issues are less of an issue when the fee is lower. Now, where do probably 90% of their dentists, general dentists, make most of their income? It's on these cases that are less than $3,500.
If you look at our laboratory, 85% of the cases that come in are 1 and 2 units.
1 and 2 units.
Yes. When you look at 8-unit cases, less than 1%.
All right.
You know, the majority of the 60 million crowns done in the U.S. last year are 1 and 2 crowns being done together.
1 and 2
So you're
crowns.
absolutely correct. That's where
And
they
so
live.
the majority of the dentists are operating at that
Right.
level. They get into a verbal habit. You get into a work habit relative to discussing fees with patients.
Mm-hmm.
The fee can almost exist in a vacuum because the fit issue is not so significant.
Right.
So if it's an $1,800 fee, you're not going to worry too much about the patient's life circumstances because they can kind of fit it in.
Right.
But what if the case fee was $8,000 or $10,000? Now how much does fit impact the case acceptance process?
Oh, now we're, a lot.
A lot.
And they could have a child in college who maybe is just 1 year away from getting out, or maybe one's getting ready to go into college,
Right.
daughter getting married. I mean, it seems like there's a myriad of things that could put a lot of stress on the financial state of a family, and then for you just to dump this on there and say, deal with it.
It becomes very unrealistic. So treatment planning in a vacuum doesn't make any sense at all, especially when you hit the higher fee cases.
So you have to know, again, we're back to relationship, because someone's got to have that conversation with the patient and find out what's going on in their life.
And who better to do
have
that
that.
than the doctor? See, who better to do that than the doctor?
Right.
Because the position that I take with this is that, you see, money is the most emotional topic you're going to have in dentistry.
Absolutely.
That's where all the problems reside. And when the dentist gets really good about talking about money, that's just a signal that the dentist has a very high level of emotional intelligence. If I'm not embarrassed to talk to you about money, that signals a certain level of confidence in me. And if you expect to have patients for a lifetime in your practice, Mike, that means that if you're not comfortable talking about money, that means you're going to avoid that money conversation for the rest of their life in your practice. And especially when those case fees get up $8,000, $10,000, $12,000, then it becomes even more important for the dentist to be involved in that conversation. I'm not saying he needs or she needs to quote the financial arrangements and fill out the insurance. No, I'm talking about what is the total care fee here and how does that fit into your life? Yes Online provides those answers about how to get into dialogues with patients about money that's easy for the patient to hear and, as importantly, easy for the team and the dentist to deliver.
Mm-hmm.
Once you understand the 4 chiefs and once you understand what concerns the patient, what they're aware of, and what bothers them, you know, that sequence of discussion I talked about, ultimately you're going to need to present care to the patient. The case presentation process, Mike, follows the 4-3-2-1 sequence in that we're going to present to the patient those conditions they are concerned about and aware about first, and present those conditions they're not aware about and not concerned about last. Now, that doesn't mean that we're not going to present. Just because someone's not interested in having a procedure done, that doesn't relieve me of the responsibility that I have as a dentist of informing them of that condition.
For example, on Michelle, she needs those 2 upper bridges. She says it's not a big deal. Nobody sees it when I smile. That's one issue, but we've got other teeth that are shifting and super erupting into the space, and that conversation does need to be had.
It needs to be had, and I might be able to talk to Michelle about those missing teeth, because replacing those missing teeth aren't really absolutely essential for me restoring her anterior teeth. But what is essential to restoring those anterior teeth is the perio in the mouth. So even though she's not concerned about it, I need to bundle that perio in with what's going on in the front teeth. Now, the case presentation process, again,
I always found that easy to do with perio because of the disability of halitosis, of bad breath, you know, and people's ability not to be able to know that. For me, talking about bad breath and actually having a halimeter in the office where we would put the straw in their mouth and measure the volatile sulfur compounds in parts per billion and do it as a part of the screening, you know, a bad breath screening, because most patients don't have a friend good enough to tell them when they have bad breath. But for us, that was our entree into the perio. But you're right, how are you going to restore these teeth? How are you going to take an impression to restore those teeth when the gums are bleeding everywhere? So
let me teach you a little trick that I teach in the Yes Online program. what the patient is really interested in is pretty front teeth.
Right.
And the perio is kind of a stepchild to that. Nobody's really interested in perio unless the patient's chief disability is she comes in and she's 60 and she's worried about losing her teeth.
Sure.
And someone diagnosed her with gum disease, so she walks in with where perio is the chief condition.
Right.
But in Michelle's case, this example that I'm using here, she really wants pretty teeth, but perio needs to go along with it. Now, the trick is by understanding what the chief benefit is, and in Michelle's case, she wants to be confident with customers. What I'm going to do, Mike, is link the benefit of the periodontal treatment to the chief benefit she's looking for.
Confidence.
So I'm going to relate perio treatment to confidence. So when I talk about perio in my treatment plan, in a minute I'm going to show you a video of a treatment plan.
Okay.
I'm going to say to the patient, now Michelle, the last thing I want to talk to you about is your gum health. Now, I'm going to recommend that while we're fixing the front teeth, that we try to eliminate as best we can any gum infection. Here's why that's important, Michelle. I don't want the infection from the back teeth spreading to the front teeth, ruining your confidence in their appearance. Gum disease like this can spread to other teeth, and it can spread to other areas of the body. You see, what I've done is I linked the benefit of something that she may not even be aware of to the chief benefit that she's looking for.
Right.
And so the true benefit of periodontal treatment to Michelle might be preservation of her confidence in her appearance.
Right.
Perio benefit to another patient may take on a completely different descriptor. If a patient is, let's say this older patient who's afraid of losing their teeth, then the benefit of periodontal treatment would be to help preserve the existing bone that we have around the teeth and eliminate the infection. It would have nothing to do with appearance.
Well, that makes sense because Michelle doesn't want to get this beautiful new smile and then have the gum disease take it down. She's not going to let that happen. She's going to do whatever she needs to do to keep the perio from doing that.
And that becomes, in confidence in her appearance, preservation or sustaining the confidence in her appearance, Mike, that becomes the benefit of perio, endo, night guards, equilibrations, hygiene visits, everything. That's the horse. That's the direction that the horse is running.
That's right. Yeah. So everything gets tied into that disability. That makes sense.
That's right. And the tool for that is the Discovery Guide. It's sitting right there in front of the dentist, right there in front of the team. And again, I'm going to get back to the tool. In the absence of the tool, this behavior won't be reinforced. You won't be reminded to use the tool.
Okay.
One of the last things I want to show you, I'm going to show you a short video of how the Discovery Guide is actually used during the case presentation. The patient's name is Patty. Patty has a discolored front tooth. You're going to see the discolored front tooth. That's her chief condition. Her disability is that her job's in a little bit of jeopardy. So's her husband, and she may be out job hunting. So she's worried that this discolored front tooth is going to get her into trouble.
Right.
She's got some mouth odor. Her daughter mentioned to her her breath was a little bad. She realizes she's got some gum bleeding. She's not sure where it's coming from, so gum disease is present. It's kind of a quadrant 3 thing for her. She's got a couple broken fillings in 3 and 30. Now, she's known about these broken fillings for years. Her old dentist, Dr. O'Malley, said, well, these teeth are cracked. If they give you a problem, we'll just wait on it when it gets to be a problem. So she knows that she has this. But
they haven't been hurting for the last 10 years.
It doesn't give her any problem. And finally, she's got some deep class 2 tooth decay between 12 and 13 that she's completely unaware of. So that's the kind of the situation 1 or quadrant 1. And what I want to do is show you a video of a case presentation where I've got the Discovery Guide tool superimposed over the case presentation. What I want you to do is listen to the case presentation as if you were the patient. The simplicity of the language. Also think about it. Imagine if a dental hygienist or a team member was using this tool. It's very delegatable. Now understand, as you watch the video, this is not the consent conversation. This is the influencing conversation. I'm going to discuss with Patty what's important to her first and what's least important to her last, and this has no correlation to treatment sequence.
Well, we're never going to get to the consent conversation if we don't get through the influence conversation and get this patient on our side and excited about this treatment and fill her with the realization that we have in fact heard what she's saying, that we get her.
All right, let's watch the video. Patty, the first thing I'd like to talk to you about is your discolored front tooth. I know that this is your main concern, and you want to be more confident in your appearance as soon as possible. All right, let me pause it here. Now, what you're seeing superimposed on the screen is a portion of the Discovery Guide tool. Again, this is the tool. And what the dentist does is fills out across the top the sequence of presentation, not the sequence of treatment.
Right.
That's the sequence of presentation. We're going to discuss from left to right, just like reading a book, what's important to her first, what's important to her least.
So he's already discovered that the disability most important to her is tooth number 9, and I would assume that's pretty common, right? I mean, it's right in the front. That's got to be what a lot of patients come in for. I need to get this fixed because whoever's getting married.
That's right.
Okay.
Because see, so much of this occurs in that new patient interview or during the examination process. See, so much of this is about listening differently.
I'm sorry, what?
And it's understanding what to listen for.
Right.
And so the dentist or the team member then can get a kind of a natural feel to this. Well, what the Discovery Guide does, it documents it so it's clear to everyone in the team. So even though in this video I'm showing where the dentist is giving the treatment plan, a dental assistant or a dental hygienist could be giving the treatment plan. So he starts on the left, goes to the right. Now the vertical columns relate to exactly or what he's going to say about each one of the conditions. He starts with telling the patient that he understands the disability. Then he talks about the timing or the readiness. Michelle or Patty, I know this is something you want done as soon as possible. Then he states the chief benefit she's looking for. That is whatever the opposite of that disability is. In Patty's case, she's embarrassed, she's worried about looking for a job, so he'll state the strong benefit of the case. Then he'll use 1 or 2 sentences to describe the process. Now, this is not informed consent, Mike.
Right.
This is just simple layman's language, and then the last thing he'll talk about is a fit issue. Then, when he's done with that column, he'll actually quote the fees. But I really don't want to get into the fee conversation right now. Just listen as the dentist goes from left to right.
Well, that about wraps it up for this edition of Chairside Live. My thanks once again to Dr. Paul Homoly for sharing his case acceptance strategies with us, and my thanks to Marshall Horowitz, who went all the way to Mongolia to take those wonderful pictures for us. On behalf of everybody here at the laboratory and the crew at CSL and myself, I want to thank you for your time and your continued commitment to quality dentistry.